Hi, thank you very much, Joshua. So today I'm going to speak to you about surgical treatment of epilepsy, and what I'm going to be doing is really an introduction to this topic. It's much too big of a topic to get very deep. I will kind of skim the surface, but I'll give you a pretty good overview, I think, of what's involved with offering surgical treatment to people with epilepsy. I don't have any financial disclosures, but you may know I am a neurosurgeon, but I actually, because of being in this niche, it's actually very similar to what you may have heard from Dr. Weintraub last week, is that I'm actually a surgical neurologist. I'm actually a neurosurgeon who operates in conjunction with neurologists on patients who have neurological conditions. And it's very different from the vast majority of neurosurgery. It's functional neurosurgery is a term we use for it, but it's actually operating on people that have a chronic neurological condition and using surgery to try to ameliorate or help these patients, which means having to collaborate very closely with neurologists, and means operating on the brain itself and not things that are near the brain or bothering the brain. We'll give you a little introduction to myself. I grew up in upstate New York, and then I went to Baltimore to Johns Hopkins for college and also for a medical school and a PhD. And then I went to Columbia to do my neurosurgical training. And back then in New York, there was no possibility to do surgery for epilepsy in the 1980s in New York. I got interested in learning it, and I was sent to Montreal Neurological Institute to do a fellowship to learn about surgery for epilepsy. It's one of the places that was really the birthplace of epilepsy surgery, certainly in North America. And after that, I had a job in New Jersey at Robert Wood Johnson. At the time, New York had not established the ability to offer surgery to epilepsy patients, but in 1991, they did establish epilepsy centers, and I became one of the first epilepsy surgeons in New York. And actually, two of my colleagues, one at NYU and one in University of Rochester, the three of us are still doing epilepsy surgery in New York after having started back in 1991 or 2. And I spent most of my career at Columbia, and then in 2011, I became chairman of neurosurgery department in New York City at several hospitals, and then subsequently moved to Lenox Hill in the most recent years. And I now collaborate with neurologists who established a department at Lenox Hill after having previously been mostly based at NYU. And I will try today to give you a sense of what's involved in treating patients with epilepsy using surgery. And first, I will show you what a seizure is. I will explain to you what epilepsy is, and then why we might think about using surgery to treat patients with epilepsy. And then how do we make the decision to offer surgery to these patients? And then I will show you at least one of the most typical types of surgeries that are done for patients with epilepsy. And then at the end, I will talk to you a little bit about how epilepsy surgery has been changing in recent years, moving more towards being minimally invasive, and also that we have actually changed our concept of epilepsy and now are using brain stimulators and neuromodulation to try to help people with epilepsy, which is something relatively new. Let's see if I can show you an example of and one more. So what is a seizure? A seizure is a sudden uncontrolled electrical disturbance in the brain that can cause changes in your behavior, your movements, your feelings, and in your level of consciousness. That first video that I showed you was a seizure. The second one I showed you was not. The second one was actually a non-epileptic seizure. It did not have change in electrical activity in the brain as the underlying cause of that episode. It was something else which we see very often, and a lot of times the only way we can distinguish, or very often the only way we can distinguish between those two, is if we have an EEG being done at the time of the episode. And then we can see the electrical activity, which you might be able to tell here in these electrodes here and here. There's activity that actually evolves and becomes rhythmic. And this is typical of an electrical activity that underlies a seizure. But this type of activity did not occur in that second person, the second video that I showed you. And so that's what a seizure is. But what's epilepsy? And epilepsy is if you have 2 or more seizures or a tendency to have recurrent seizures, then you have epilepsy. One seizure is not epilepsy. And what is the problem with living with epilepsy? It's not such a terrible problem to live with if you take medication and it prevents you from having seizures and you live with the medication without having bothersome side effects, if you can function normally on the medication. And it's not necessarily a trivial matter, but it certainly allows people to live a fairly normal life. The real problem is that medication does not always achieve complete seizure control without bothersome side effects. And it turns out there are a lot of people with epilepsy living with the problems related to having medically refractory epilepsy. It causes a lot of problems, but the most significant issue is that it impairs independence. People living with refractory seizures typically are not able to pursue a completely normal independent life. They are unable to drive a car, operate heavy machinery. It limits their employment options. And their family members typically worry about them, and their interactions with others are affected by the fact that they live with episodes with epilepsy, with seizures. And it limits their ability to pursue relationships. And there's also a mortality risk associated with living with refractory epilepsy. We actually know that there's actually a 0.5% chance per year of a patient with refractory epilepsy of dying because of their epilepsy. It's somewhere between 0.5 and 1% a year. And epilepsy is a fairly common disorder. 5 to 10% of people will have at least one seizure, and 30% will develop epilepsy, so that at any one point, over 0.5% of the world's population is living with epilepsy, which is a very significant disease burden comparable to breast cancer in women or lung cancer in men. And for patients that have seizures that are not controlled by medication, those people account for 80% of the cost of treating people with epilepsy. A study done about 20 years ago showed that there had been a number of new anti-seizure medications developed over the prior 20 years. But even with these multiple new medications, and there have been many since then, it turns out that still, if you're not made seizure-free by the first anti-seizure medication that you go on, the chances of becoming seizure-free with additional medication is low. In fact, if you fail to become seizure-free with 2 different medications, then your chances are very low of becoming seizure-free over a long period of time. This is just, I referenced that mortality is an issue with living with refractory epilepsy, and in fact, it can be calculated that a typical patient that has, let's say, temporal lobe epilepsy, which is the most common type of epilepsy that is refractory and leads to surgery, that those patients, if the typical age might be 35 years old, if a 35-year-old person with refractory epilepsy has temporal lobe surgery, it extends their life expectancy by an average of 5 years. So it's not just to get rid of seizures so that people can live a more normal life, a better quality of life, but it actually also extends life expectancy to eliminate seizures with surgery. And so how do we really decide on who might be a candidate to consider for surgery? As I said, people that continue to have seizures, even though they've tried at least 2 medications at appropriate doses, and if they have seizures that are impairing their quality of life, and also they understand that they're living with a risk of mortality because of having ongoing seizures. The primary goal of treatment when we treat patients with epilepsy is to achieve seizure freedom, having no seizures. With surgery, we would certainly consider that if it can be achieved with an acceptable risk or low risk of morbidity. Sometimes we pursue surgery to lessen the impact that the epilepsy has, to reduce the severity of the seizures or reduce the frequency of the seizures, which can improve the quality of life for patients living with epilepsy, reduce their need for medication, but not necessarily eliminate their seizures completely. Patients who have refractory epilepsy should be evaluated at a comprehensive epilepsy center, a center where there are neurologists who specialize in epilepsy, epileptologists who are working with a surgeon who specializes in offering surgery to patients with refractory epilepsy. At Lenox Hill, we have a large number of doctors, particularly it's multiple specialties, but I want to emphasize that the neurologists, the epileptologists are the key to taking care of patients with epilepsy and to offering optimal care, including surgery. It can only be done as a team effort. What I've told you up to now is basically all I want you to know about surgical treatment of epilepsy. I'm going to tell you a lot more, but really the take-home messages are what I've already said. I do want to give you more information about how we assess patients for surgery and then the surgery that we actually can offer them. Semiology is a term we use to describe what we see, the manifestations of a seizure. What happens to a person while they're having a seizure. And even though people can describe, patients themselves can give us some inkling of what they're feeling or what happens during a seizure, and people that have witnessed their seizure can tell us, we learn best about what happens during a seizure by monitoring and actually recording with video and simultaneously with EEG what happens to a person during a seizure, and also to be able to examine them during and after a seizure. And one of the things we want to know is was there, did a patient have an aura? Did they have some kind of feeling before the seizure became more severe? Because that often can give us a clue as to what part of the brain is involved at the beginning of a seizure. An aura is what a patient can remember from their seizure, or especially at the beginning of their seizure. And sometimes we refer to it as what the patient is aware of before they lose consciousness, but actually some seizures happen without loss of consciousness, so it's not technically the right term. And in order to use the information about an aura, in order to use the information about what we see, the semiology of a seizure, we need to know about the brain anatomy and function, where the functions are located in the brain. And so just to give you a very a rough idea, you know that there are various lobes of the brain, and also another area that's become much more of interest in recent years is that the insula, the part of the brain that's actually hidden by the edges of the frontal and the temporal lobes, this insula actually can be the source of seizures, and now has become much more of interest in being considered when we evaluate patients with epilepsy as a possible source of their seizures. And as far as locations, this is not exactly an accurate depiction, but gives you an idea of where different functions are located. Hearing is actually probably should be located further back here, just in front of where the vision area is. And language in the left side for most patients is in this area that we find language located in. Memory, function, and learning involves the inner part of the temporal lobe, actually both, but for most people, it's their dominant hemisphere that is their predominant location for learning and memory, learning new information. So when we watch seizures, we're looking for signals of what area of the brain might be the source of the seizure. This patient is conscious, and she knows that her seizure is going to make her start spitting. So she grabs a basin and spits into the basin. And that, we know, is likely to be the non-dominant temporal lobe that is the source of her seizure. This patient, It's not clear whether the smiling and the laughing is part of her seizure, but now she knows that she's having a seizure.
Who's that? Me, Danielle. Okay, can you remember 3 items? Alligator, spinach, storm. Okay, can you point to the ceiling, raising both arms?
Left arm can't move. Okay.
It's all right. All right.
You can see there that she was able to talk at the beginning. She then was unable to talk, and you could see that her left side was stiff, and she was still able to use her right side. So it indicated that the seizure was evolving in the right half of her brain, affecting the left side of her body, and that most likely the left side of her brain is where her verbal function is. That's why she was able to stay verbal for a while as the seizure evolved. This patient is mute, not saying anything, and he has repetitive movements of his mouth, which are automatisms. This is typical of a seizure that is likely starting in his dominant temporal lobe, probably his left temporal lobe. And if you watch his hands, you'll see that his right hand starts to get stiff.
Remember the number 10?
But he's able to still move his fingers with his left hand. And he does repetitive movements with his left hand. That's also an indication that the seizure is evolving in his left hemisphere and most likely started in his temporal lobe because of those automatisms. The seizure already started. You can see she's actually able to move her right side. Her left arm is stiff or not moving, and she goes down to the ground. She's still moving her right side, and probably not verbal. This is also, I mean, we don't know if she's verbal, but her left side became stiff. Her right side's still moving. So this seizure started in the right side of her brain. And it hard to know what area, but it could have been temporal, or it could have been somewhere else in the right hemisphere. Automatisms, as I mentioned, can occur during a seizure. They can also occur afterwards. And for people that remain conscious and have automatisms, it often indicates that their seizure is evolving in their non-dominant, usually the right temporal lobe. And they typically, while patients are having automatisms, typically do not respond to external stimuli, at least certainly not normally. And sometimes they'll exhibit behaviors that normally would be socially inhibited behaviors. And they're typically repetitive movements. Posturing, motor changes that occur can give you an indication of what part of the brain is involved. Asymmetric tonic posturing indicates frontal lobe origin of a seizure. And offensor posturing indicates that the supplemental motor area, SMA referred to here as an area just in front of the primary motor cortex, might be the area involved in that seizure. And dystonic posturing, which we saw some of, can indicate a temporal onset with spread into motor areas afterwards. Here's another example. I don't know if you can see it, but if you look at her mouth, you'll see mouth movements. And this becomes a motor seizure, and involving her left side probably more prominently than her right side. This is what I meant by posturing. It becomes a secondarily generalized seizure now. But the important thing is, where did it start? And this is the seizure that I showed you at the beginning. Just see it again. This has some characteristics that are typical for being a frontal lobe seizure. Most likely he was asleep when the seizure started. It's typical for seizures that start from the frontal lobe, and they often are hypermotor seizures like this with violent movements. But he is not conscious of what he's doing right now. And for one of the most common seizure types that end up being refractory and end up being candidates for surgery are seizures that start from the inner part of the medial part of the temporal lobe. And those very often, patients have an aura involving a sensation in their abdomen, the epigastric area, with a rising sensation, often very difficult to describe, sometimes with some queasiness or nausea. And they often have movements of their face or hands that are automatisms, and then often after the seizure will cough. Those are indications that the seizures might be coming from the medial temporal lobe. Also, there are very characteristic EEG changes that we see when seizures are starting from the medial temporal lobe. Typical rhythms, electrical rhythms that we'll see, and we'll talk more about temporal lobe seizures in a bit, but I'll give you an idea of what we're looking for in these EEGs, where you see sometimes this rhythmic, there's large waves or slow rhythm waves that are coming only from the right temporal lobe. This is the left, this is the right, this is the left, this is the right. And you can see if you compare the left and the right all the way, that the right side has this rhythmic discharges. Here also spikes. This is not a seizure, but it's an indication that the right temporal lobe is irritable and might be the source of seizures. And then when you see an actual seizure start, these are all the right temporal lobe electrodes here, here, and here. And you see how they evolve into this rhythmic discharge, which is typical of a seizure, but it actually starts back here where the first change happens from the prior baseline. So when we evaluate a patient that has refractory epilepsy, we need to know their history, when their seizures started, how often they have seizures, what medications they've tried, what other medical problems they have. And then the two most important aspects of evaluating patients once we suspect that they have refractory epilepsy would be to do brain imaging, to look at high resolution at their brain to see if there is an indication of where seizures might be coming from in their brain, a structural abnormality. And also we do the video EEG monitoring, as I told you or showed you, where we can monitor a patient and actually record their EEG between and during seizures, and at the same time videotape them and also evaluate them while they're having a seizure or right after a seizure, to get an idea of what type of seizure they have and where it might be coming from. Those are the most important aspects of the evaluation. An example of what we might see in an MRI, this syndrome of mesial temporal sclerosis, which actually used to be much more common than it has been in the last 10 years. Some reason it's occurring much less than it used to, but people develop some type of a change in their hippocampus that occurs probably at before 2 years of age. Sometimes it can be bilateral, but very often it's either unilateral or very asymmetric, so that only one hippocampus looks like it's involved, and the hippocampus becomes smaller, and also it becomes scarred, which we can see in an MRI because it becomes more white. And you can see that the hippocampus here, where these arrows are, is smaller and rounder than what it should look like over there. And there are other lesions that can be focal, small lesions that can be in the brain, maybe not so small, but that can often be epileptogenic or generate a seizure focus. Cavernous malformation is one example, which is this lesion here in the anterior temporal lobe of that patient. This is a kind of a heterogeneous abnormality here, which turned out to be a low-grade non-growing astrocytoma that was present for many years, causing seizures from the temporal lobe in that patient. And this is an area which is a tumor that is actually of neuronal origin, not glial origin. And these type of tumors often stay static for many years, may have been developed in early childhood, and often cause seizures as the only manifestation. They often do not grow. Another abnormality which we see quite a bit as the underlying cause of epilepsy, focal epilepsy that can be refractory, is a maldevelopment of the cortical mantle, cortical dysplasia, which has a variety of different manifestations. Sometimes dysplasia can be visualized in an MRI as a very mild or very subtle abnormality. Here you see that the gray and white matter don't look as distinguished from each other in this area as they do over here. You can see the gray matter at the surface and white matter is dark in this MRI, but over here, there's much more blurring, much more gray matter. This is an example of dysplasia, which usually is not discretely, does not have a discrete border. Usually it transitions very gradually from an area of dysplasia to normal brain. Very often it's difficult to identify the margin where the dysplasia ends and where normal brain begins. And other type of imaging that we use is functional imaging. A PET scan, which is a way to identify areas of the brain that are hypometabolic, which can be an indication of where a seizure focus is. That could be at any time in between seizures, you could see that. And another type of functional imaging, which is very hard to obtain, but can be extremely useful, is SPECT imaging, where we inject an agent which can be taken up into the brain at the beginning of a seizure. And then afterwards, imaging can identify the area where the uptake was. And that can be a very good and sensitive way to identify a seizure focus onset. Here's an example of a PET scan where the left temporal lobe, this patient looking at us, the right temporal lobe is on our left and the left is on our right. But this area is much blander, much lighter than this, indicating that that area has less metabolism. You can see on an axial view here, same idea. This temporal lobe, which is the left temporal lobe, is much lighter than the right, indicating that that is likely where the seizure focus is. And here's an example of that SPECT where the ictal onset, it can be identified by giving an agent right at the onset of a seizure, gets taken up by the brain in the area where the seizure is beginning. And functional MRI is used very frequently to identify areas of function in the brain. Can help us to identify which side of the brain is the language side. This is an example, a recent patient of mine who I'll show you in a few minutes, that this is the right side of the left side of the brain, the right side of the picture is the left side of the brain, and he's a right-handed patient. And this is an area that had uptake where when he was asked to generate a verb, the blood flow in this part of the brain increased, and this part of the brain, the receptive area. And this imaging can detect an increase in blood flow. Here's an example of object naming where vision is being used to look at an object and then name it. So both the visual area lights up bilaterally, but then only the left side lights up in the area used to identify the object. And here are examples of identifying motor and sensory cortex in that same patient, where the left hand, this is now the right side of the brain, the left index finger tapping, this would be motor for the finger, and right behind it is an area that is sensation for the hand. When the palm is stroked, that activates. And other parts of our evaluation involve neuropsychological testing to assess cognitive function and to identify if certain functions might be impaired, which could be indication that that area of the brain has been affected by a seizure focus. Can often indicate right versus left changes or different lobes that might be affected, frontal lobe versus parietal or temporal lobe. We use, if the functional MRI is not capable of doing it, we use a WADA test sometime, very often actually, to partly lateralize language by injecting into the carotid artery one at a time, the right and the left. We can inactivate half of the brain and identify the function coming from that side or the opposite side because the function is maintained. This is particularly used to evaluate the ability of each temporal lobe to create new memories. So that if we inactivate the left temporal lobe with this injection and patients are able to remember well, then it indicates that their right temporal lobe is capable of retaining new memories. And we often use this before we would decide whether to recommend removal of the hippocampus or the medial temporal lobe, which is especially difficult decision to make in the dominant hemisphere. Magnetoencephalography is something that we often use. It's another way of identifying epileptiform discharges in the brain, different from an EEG, and often supplements what we learn from an EEG. But it's critical that we put together all of the information that we get when we're evaluating a patient, and we make a team decision. We have a conference where everyone of interest from various disciplines is together. We discuss a patient in detail, and we make a joint decision as far as recommending a surgery, and if we recommend surgery, what type of surgery we're going to recommend. It involves sometimes we are able to identify a single seizure focus. If it's most easy, if there happens to be an MRI abnormality that correlates with where the seizures are coming from. If patients have unilateral mesial temporal sclerosis, it can often be very straightforward to be able to recommend surgery. But patients that don't have a structural lesion on the MRI, which is a very large percentage of our patients, really the only way we have a chance to offer them surgery is to use electrodes that are implanted on or in the brain and then recording from them to identify where seizures are coming from. Sometimes we don't know if the seizure is starting on the right or the left. We often have to place electrodes on both sides of the brain and record from both simultaneously to see which side the seizures are starting on. And if we do know what side, very often what we're doing is then making a hypothesis based on our information about where we think the seizures are most likely coming from, and then covering that area and strategically some other areas to try to answer the question as to where the seizures are starting from. And to be a little simplistic, basically we can divide epilepsy sort of into two categories. There are primary generalized epilepsies and there are focal onset epilepsies. And the primary generalized epilepsies are typically controlled effectively by medication, but the seizures that are focal onset have a very high chance of being refractory. And the basic principles with surgery, as I've alluded to, is to identify where the onsets are of a seizure of a particular patient. Hopefully their seizures are all coming from the same area, they're all the same seizure. And then if we can identify that area and then make sure that that area is not serving a critical function, we could then recommend removing it. There have been some studies done that document the efficacy and safety of epilepsy surgery. It's only one actually prospective randomized trial that was done. It was done in Canada because patients typically there, when they became candidates for a temporal lobe surgery, had to wait 1 year before they could have surgery. So they randomized patients and were able to offer surgery to patients that were randomized to surgery one year before the other patients could have it. And during that 1 year, we're able to compare the outcomes. And patients that had surgery, had 64% of them were seizure free, and only 8% of the patients that continued with medical management. We also I participated in a study when I was at Columbia that was one of the best, was one of the only at the time it was the first multi-center study that was performed of epilepsy surgery where multiple centers collaborated, and we actually used the same approach to offer surgery to patients, and were able to get a very large number of patients to evaluate over a short period of time. And it was valuable in identifying what the outcome was from surgery. Most of the patients were temporal lobe patients. Patients that had temporal lobe epilepsy had a 77% chance of being seizure free for 1 year. Patients that had seizures coming from somewhere else in the surface of the brain had a 56% chance of being seizure free. And there were 8 deaths that occurred during follow-up, but only 3 occurred among the patients that were seizure free. And when we do invasive recordings, when we are implanting electrodes, we have a choice between putting electrodes on the surface of the brain or putting in depth electrodes, small, very thin electrodes, that needle type electrodes that go into the brain substance. And depending on what questions we're asking, and also different centers have different approaches as to which they're going to use. With the surface electrodes, we can, well, actually with both, we can do cortical stimulation to help us identify functional areas. So the most common type of surgery for epilepsy is a resective surgery where we identify a seizure focus and remove it. But there are other surgeries that we do which can be very helpful, which may not eliminate seizures, but can often be very helpful, like a corpus callosotomy, or doing a hemispherectomy, which often is curative, or something called subpial transections, where we actually make cuts in the brain but don't remove any brain tissue, and very often can disrupt electrical spread and seizures without affecting function from that area of the brain. And recently there have been new ways to offer treatment to patients. One is to replace open surgery with a more minimally invasive approach, either with radiosurgery targeting radiation to, let's say, the hippocampus, or now that's really been replaced by using laser lesioning, by putting a catheter into a target and heating that part of the brain while the patient is in the MRI. We can monitor the temperature of the brain with the MRI as we create a lesion. And as I mentioned before, we've evolving towards using brain stimulation to help people with epilepsy, and there are 3 different modalities that have been developed that offer help to patients by not destroying any brain tissue, not removing any brain tissue, but by stimulating the brain and modulating or altering brain function in a positive way. It's a very safe way to try to help people that have epilepsy. Just to talk a little bit more about temporal lobe seizure patients. Typically, I already have mentioned this before, very often patients with mesial temporal epilepsy have it from mesial temporal sclerosis. Those patients have had a complex or prolonged febrile convulsion early in childhood, maybe an indication that they have it, or it might actually be part of the cause of the damage to the hippocampus. They often have auras, and then they sometimes will have secondarily generalized seizures. Very often they start having seizures in childhood, but then have a period of time where the seizures are controlled, either without or with medication, and then have recurrent seizures in in adolescence or in adulthood, and then they may often become refractory to medication. I'm going to skip that, but I showed you already an example of sclerosis. You can see this is a sclerotic hippocampus on the right and a normal appearing hippocampus on the left. This is a histology showing the cells, and there's a loss of neurons that's quite evident in this case, and it's replaced by scar tissue by glial cells. A typical EEG I showed you before, where you can see that this is certain electrodes are showing you where the onset of the seizure is, rhythmic discharges coming from one side. Sort of a rough idea of how we might do surgery. The goal of this surgery is really to remove the hippocampus and the tissue right next to the hippocampus, which obviously is deep. And one of the safest and best ways to do this is to remove a small part of the temporal lobe and at the tip to be able to access with a microscope to the deeper part of the temporal lobe to be able to remove the hippocampus, which is where my arrow is there. This can be done through a small incision with minimal haircut. And this is where the hippocampus is. They see this red area is the hippocampus. It's called seahorse because it reminded early anatomists of a seahorse. And here you can see this is the left hippocampus looking through a kind of a 3-dimensional brain. The temporal lobe here has been, part of it's been cut away, obviously, so we can see through. Choroid plexus sits next to the hippocampus. This is an example of a hippocampus that I removed during surgery. This is a left hippocampus there. And another type of patient which we often see is a patient that has seizures which have an appearance of possibly coming from the temporal lobe. This patient particularly had changes in the hippocampus that were consistent with mesial temporal sclerosis, but also it had a stroke of the left hemisphere involving areas well outside of the hippocampus. And it wasn't possible for us to blame just the hippocampus for his seizure onsets based on our workup with external electrodes, what we call a non-invasive workup. So we did pursue implantation of electrodes. This is a schematic to give you an idea of how we can place electrodes on the surface and on the undersurface of the temporal lobe. We also placed a depth electrode into the hippocampus in this patient. And this next picture is not that particular patient, but just to give you an example of what it looks like when we do a grid and strip implant. We expose sometimes a significant part of the brain surface and then place these electrodes, and they have wires that come out and come through the small holes in the skin, and everything is closed up, and then we monitor with those electrodes in place for often more than a couple of weeks to be able to record seizures. This patient had seizure onset similar to what I've shown you before with, in this case, his seizure onsets were strictly from the medial temporal, from the area of the hippocampus. And he had a resection like the one I just showed you, and he ended up a year later was working, and within 2 years was driving, and then pursued a career and relationships, something that many patients are only able to do after becoming seizure free. So to kind of summarize, the 2/3 of the patients will become seizure free after temporal lobe resection, and their quality of life is typically dramatically improved because they've eliminated seizures without a significant morbidity. And the morbidity of the surgery itself is quite low. One other thing, I just want to show you a couple other things quickly before we finish. In recent years, there's been an evolution in North America, in the United States especially, more towards using depth electrodes to evaluate patients more so than using those surface grids and strips. And I had a patient that had, 39-year-old man, had seizures since he was 9 years old, that involved often just a sensation in his left arm, but often these seizures would progress to a secondarily generalized seizure. So we had reason to suspect that the right parietal region was the likely source of his seizures, possibly temporal lobe, possibly insula, but we knew it was the right hemisphere. And he also had, although it's subtle probably to pick it up, his right hemisphere was somewhat atrophied, somewhat smaller than his left, but it was globally changed. It wasn't in any particular area of the right hemisphere. So we planned a placement of electrodes, many electrodes in the right hemisphere, to sample different parts of the brain. And this is just an example of where the electrodes were targeted. And then by creating 15 placements, 15 trajectories, I bring the patient to the hospital to put in several screws into the skull through tiny incisions, and then get a CAT scan which shows us those screws. The patient goes home, but I use imaging to make a plan for placing all of these electrodes, and then a company creates this platform. It's a 3D printed plastic platform that can be attached to the screws that are in the skull and are used to guide placement through these little openings here, placing the electrodes through very small openings in the skull, twist drill openings. And when we recorded from this patient, you'll see the seizure onsets were a sudden burst of high frequency activity from just a few electrodes. These were all next to each other in his right parietal lobe. And that allowed us to recommend a resection. And this is an idea of where this picture is taken from. And this, the black outline is the area basically that's exposed of his brain. And this is the area, the yellow outline there is the area that I resected. And just in front of that is his primary sensory cortex and motor cortex for his left side. And he had no seizures subsequently, and also his function was completely intact. I'm going to try to see if you can listen to this. There's pictures being displayed here. And this is an indication of electrical current being delivered.
You see where that was?
That is a key. And for Tiber,
You see how he
this is the right vascular.
wasn't able to speak. She wasn't able to speak for a sec.
This is a picture.
So there's one spot, they tested many different spots.
This is a book.
This is an example of cortical stimulation we do with patients awake in the operating room, especially to identify language areas. And by stimulating in different areas, we can identify which area is critical for speech output and also for comprehension, naming. You know, I started as an epilepsy surgeon in 1989. From 1989 to 2013, there were really very few changes in how we offered surgery to patients with epilepsy. But since 2013, there have been a number of changes. Partly it has involved becoming more minimally invasive in order to offer lesioning of the hippocampus and other deep structures. But the most dramatic change has been the ability to offer these different types of stimulation approaches to people that have epilepsy and help them without removing part of the brain. Radiosurgery is using focused gamma radiation to try to actually just lesion, destroy a deep area of the brain. And it was proven to be effective in treating the hippocampus, but before it was really proven, another technique developed which turned out to be much better, which is to use a laser, the thermal lesioning of the brain using a laser with a patient's brain in the MRI so that we can monitor the temperature, and we can accomplish the same thing that you can do with radiation, but do it through a tiny hole in the skull with a tiny catheter and do it very safely and have an instant result. And it's been proven to be very effective. I'm just going to show you a couple pictures to give you an idea of how this is done. By going to certain temperatures, we know what temperature will cause destruction. We can target and make sure that only the areas that we want to injure are allowed to have their temperature rise above the the critical level. It's kind of an example of how in the MRI we can actually see what part of the brain is being heated as we do it. Here, down here is an example of the lesioning, and here the hippocampus seen longitudinally from the side. Just to give you a very quick idea of how this is done in steps, we put a tiny catheter through a tiny opening in the skull, and then in the MRI we can be sure that the catheter is exactly where we want it and do the heating. Something that's really evolved in recent years is that we now don't think of epilepsy or focal epilepsy the same as we used to. We used to think that most patients had a single area of the brain that was producing their seizures, and seizure would start there and spread to other parts of the brain. Now, the theories have evolved where we now know that different parts of the brain are connected to each other, and that these networks interact with each other, and that seizures can jump from one to another, and also multiple nodes of the network can be involved in seizure production, not necessarily just one. There may be one predominant one, but removing that one may not alleviate the problem of seizures coming from other nodes, and the activity can jump into significantly different parts of the brain through these network connections. And this reinforces the reason why stimulation of the brain might be helpful, because we can use stimulation to modulate the activity of the brain, sometimes diffusely, without causing, with very, very low morbidity. Vagal nerve stimulation, stimulating the left vagus nerve with an implanted device, is a way to achieve significant reduction of seizures in a high percentage of patients. Another way is to do deep brain stimulation, and various targets could be used. The anterior nucleus of the thalamus has been proven to be a place that can reduce seizures. And responsive neurostimulator, this is a device that I worked with the company to develop, is a way to monitor electrical activity from two leads that can be placed in the brain, depth electrodes or surface electrodes. And we try to put these electrodes in a place where the seizure is going to begin, and then deliver electrical stimulation through this device, which over time in many patients reduces their tendency to have seizures, in some cases can dramatically reduce it. And this is also a very safe way to offer benefit to patients that have refractory epilepsy. This also was studied in a randomized study, just like the brain stimulation. These devices have to go through a prospective randomized study to prove efficacy and safety before they can be approved. And they are all three devices approved to be used for patients with epilepsy. Just want to very briefly explain to you how I ended up being a brain surgeon. And you may not be able to see it, but these Life magazine articles were from 1971. When I was in high school, I read about the brain in these magazines, and it fascinated me that we knew different parts of the brain had various functions. And I kind of knew I wanted to be a doctor, but this is what really kind of made me focus on the brain. And as an epilepsy surgeon, I get to actually operate on normal brain tissue, at least what looks like normal brain tissue. And we can only do that because we are able to get a fairly good understanding of which parts of the brain are critical, which parts of the brain are causing seizures and can be safely removed. Dr. Penfield is one of the pioneers of epilepsy surgery. He was at the Montreal Neurological Institute, and he had a saying that that having no brain was better than having bad brain. What we're trying to do is identify areas of bad brain that can be safely removed to eliminate seizures. And patients that have lived with epilepsy and get cured by surgery are some of the most gratified patients that I've ever taken care of. So I will try to answer any questions I can in the whatever time we have left.
I opened the chat up if you want to stop screen sharing and take a look at the chat.
Stop screen sharing. I guess I do that, right?
Yep. And then you just have to click the chat button.
Wow. So where am I looking? How successful is DBS for patients with epilepsy? Unfortunately, what it does is it reduces the frequency of seizures, just like pretty much the same way that vagal nerve stimulation can do, maybe more effective in different patients than are helped by vagal nerve stimulation. It typically doesn't eliminate seizures, but about 30%, maybe somewhere between 30 and 50% of patients have more than a 50% reduction of their seizure frequency. What is the most interesting thing I've seen throughout my career? Oh boy. You know, typically as far as seizure frequency, the patients mostly have 3 or 4 seizures in a month. Sometimes patients can have daily seizures, especially children. I don't know, the most interesting thing, I suppose, is that we can do, in some patients, do hemispherectomies where we actually can disconnect an entire hemisphere, sometimes a hemisphere that looks fairly normal, but we know is not functioning and is causing very often 50 or more seizures a day. And by doing a surgery, which is a rather aggressive surgery, and disconnecting that hemisphere, we can have a dramatic benefit. And very often it's in children. And seeing that these children can, and one of the most fascinating things is very often in between seizures, these kids are significantly impaired in their functioning, have trouble learning, even though they're not having don't seem to be having a seizure at that time. But when they've had this surgery and their seizures are eliminated, they start progressing in their development. And it's incredible to see, and it's extremely gratifying to parents. Long-term memories, I asked about whether removing the hippocampus can affect long-term memory. No, the hippocampus is for making new memories. In fact, their famous HM patient that had bilateral hippocampal resections could not make a new memory, but he was able to tell you about things that happened before his surgery that were very clear recollections and accurate recollections, but could not retain any new memories. And do electrodes ever get infected? Yeah, we have about a 1% chance of infections when we do implants with the depth electrodes, well, less than 1%. But with the grids and strips, there's a significantly higher risk of infection, probably somewhere between 5 and 10%. Those patients, typically we can eliminate the infection very easily by when we remove the electrodes and wash out the infection and give antibiotics. Does posturing cause pain? Very often these seizures, that some of the ones I showed you, cause a lot of pain when the patient is conscious. The ones that come from the non-dominant hemisphere can have very severe pain with their seizures. What is the worst case I've seen? I'm not sure I could come up with that. I've seen many patients that have very severe epilepsy that are dramatically helped by surgery, but unfortunately a lot of patients that cannot be offered surgery successfully. How do neurologists compensate for the diffusory part of EEG? So yes, EEG, especially scalp EEG, is recording electrical activity that has to travel through the brain, through the dura, through the skull, through the scalp to get to that electrode. So it's looking at a volume of tissue, and it's picking up activity that's very far away from where the electrode is sitting. So it requires a lot of interpretation, and it's not precise. There are some characteristic findings that allow them to make pretty confident conclusions, but the electrodes that we put into the brain only identify activity coming from a tiny part of the brain where the electrodes are sitting, which is really critical to keep in mind when we're evaluating patients with implanted electrodes. We're only seeing where we put those electrodes. We're not seeing what's going on in other places, and we cannot cover the whole brain. So we have to keep that in mind when we're interpreting. It's also part of the reason why the hypothesis we use to place electrodes is so critical. And deciding which one gets DBS and VNS, not easy. A lot of that depends on the neurologist and their attitude, their bias about which they like. But very often, if it's a toss-up, we would go with vagal nerve stimulation first, partly because the patients are more likely to accept that. And if vagal nerve stimulation doesn't offer enough benefit, then they can still be a candidate for deep brain stimulation. What makes tumors cause seizures and not other symptoms? Well, we don't know the answer to why questions in medicine, but I can tell you my guess. You know, seizures, tumors can irritate the brain adjacent to them. The cavernous malformation, not technically a tumor, it's actually abnormal blood vessels where there's been hemorrhages, and hemorrhages in the brain are particularly annoying to the surrounding brain and can cause seizure foci to develop. Tumors typically can only cause problems if they're growing, but there are many tumors that are static that the only way they can affect the surrounding brain is by disrupting function and causing a seizure to develop. What would quality of life for somebody whose hippocampus is removed? Well, typically the non-dominant hippocampus is not important. So patients can have their non-dominant hippocampus removed without noticing any change in their memory function. It's the dominant side that's more critical, but very often those patients have already lost the functioning of their dominant hippocampus. Many patients have developed a progressive loss of ability to retain new memories for years prior to their having surgery. So they have already lost the function from that hippocampus and transferred it over to they're using their non-dominant hippocampus as best they can to provide new memories. So those patients, sometimes we can tell ahead of time, will be able to tolerate removing that dominant hippocampus without much change. But there are many cases where we can cause a significant impairment, and there's a trade-off, and we have to decide if it's worth it to get rid of the seizures and cause the patient to have to deal with an increased difficulty with retaining new memories. Patients who had shunts at a higher risk for developing epilepsy, very, very low chance that shunts will cause seizures to develop. The case with the 39-year-old, 9 years old, what can cause seizures? Well, it may have been dysplasia. Very often when patients have no discrete abnormality that we can see on their MRI, we think it is dysplasia. Very often that dysplasia is very subtle. It's often difficult even for pathologists to identify dysplasia when we've removed the brain. That patient did have a subtle dysplasia, but it may not have been just restricted to the area that was removed. It could have been more widespread than that. Sometimes it involves a whole hemisphere, but maybe that some areas are more severe than other areas. Do you think the field is going to move further in the minimally invasive directions? You know, for lesioning, using the laser to make lesions is a great technique, but it's also somewhat limiting because very often patients don't have a discrete tiny area that can be eliminated and successfully get rid of their seizures. And those patients, I think it's critical to remember that if those minimally invasive techniques don't accomplish the goal of seizure freedom, that we should still consider offering them more traditional surgery, which has a better chance of giving them seizure freedom. But I think we are going to move more and more in the direction of trying to accomplish things with minimally invasive techniques. And in fact, imaging techniques, probably the biggest developments are going to be improved ways to image the onset of seizures. Patients with anti-NMDA receptor encephalitis present with seizures. How often? I can't tell you that off the top of my head. That's a Google search. Why are seizures more likely to originate in the temporal lobe? As I said, we don't know the answer to why questions. I can tell you for sure it's a fact that the temporal lobe is the part of the brain that's best able to cause seizures. Could be that the hippocampus is the reason because of its own structure. It's a primitive structure, and it may be that that's why it's able to generate seizures so effectively, but it's just a fact. In the future, we'll be able to implant electrodes permanently in the brain and possibly reduce. Yes, these electrodes that I'm talking about, the devices are permanently implanted, and they actually progress. Patients with those implants often progressively improve over months and years with ongoing stimulation. I think our time's up, huh, Josh?
Our time is up, but thank you so much for joining us and presenting today. You know, we got up to 1,200 people there at the end for you.
Okay, thanks a lot. My pleasure.
Have a great day.